All right, next up today, we're going to be talking about Achilles tendon injury, and we're going to really get in and compare the conservative versus surgical treatment approaches. And Dr. Swan from University Orthopaedic Associates, he's a sports medicine surgeon. He's going to talk about some evidence-based approaches that he uses and that he's done some research on to really get into that. So KG, really glad to have you on this episode to break down. I enjoyed your talk, and it's ironic, just one of our situations today, one of our athletes at one of our schools had an Achilles tendon rupture. So, so it's like the timing of it was, when you put this out there on Monday and today is Thursday and it just happened, it's like right in my head, I'm thinking about that stuff. So thank you for talking about this topic. First, I want to just ask you, can you compare those non-surgical and surgical approaches, talk about like healing rate, time frame, and maybe just give some general overview of when you do one versus the other and what we have to think about as athletic trainers?
Sure. And thanks, first of all, thanks for having me, Ryan. Pleasure to be here. There's a lot to think about and a lot that goes into it. With many things, and especially with Achilles ruptures, it's all about the patient, the individual. Where are they in their life? How old are they? What are they doing in their life? What got them into this situation? Are they on a particular team? Are they the quote weekend warrior? Are they older than that? Do they have any other health conditions, comorbidities that would put them at risk for some of the surgical complications that we really do worry about in certain patients? And so for me, it separates patients somewhat into the somewhat, if you want to call them intense athletes or very involved athletes. Certainly the younger athletes, the pro athletes, high school or college athletes who have a long career ahead of them, they are all potentially going to fall into that surgical category. And then the others, more the weekend warrior type, or those with comorbidities that put them at risk, are ones who potentially fall more into that non-operative cohort. And people do cross over in both directions, but for the weekend warrior type, the majority of the evidence does tell us now, this newer evidence over the past decade, that a non-operative treatment protocol is, number one, safe, and number two, effective. And these are two different things, really. Is it going to heal? And is it going to re-rupture? Yes, it's going to heal, and we can very much decrease that re-rupture rate and improve that functional rate if we follow the newer protocol, which is the earlier range of motion and the earlier weight bearing than what we used to do a few decades ago.
I love how you mentioned that, because that was really eye-opening during your presentation, talking about the importance of early protected range of motion. And that goes in a lot of things right now. A lot of times where it'd be like, protect it, cast it, isolate it, and a lot of different kind of rehab now really benefits we're seeing from that early range of motion and weight bearing. And this is applicable in Achilles rupture too. So can you get into that? Why is that important? And what are we seeing in the outcomes of those that are starting that right away?
Yeah. And so it is interesting. And I guess the natural concern or the natural tendency is often just to lock something up and try and let it heal and don't let it move and let it heal right where it is, whether it's maybe that comes from our knowledge of fractures, which we often have to keep stable to let a bone heal. It does need a relative amount of stability. But on the other hand, many fractures do want some weight bearing. We know that from our biomechanics in orthopedics. And the same goes for tendons, but that took us a little longer to figure out. Animal literature, as I mentioned in my talk, has shown us that, once again, not only is early weight bearing safe, but actually early weight bearing increases the amount of collagen around that healing tissue. So there's more tissue and it's stronger. So early weight bearing is important for that. And similarly, early range of motion in some of the literature shows us that it's a better construct once it heals. It's got to be done in a controlled fashion. Both of these, obviously, you can't go running on an Achilles after it's been injured, but in a controlled fashion, it does actually help the healing.
And I think that's the most important part of it is, we're seeing that structural change from that load, the collagen enhancement. which is hopefully going to reduce the risk of re-injury, and it's going to set them up for better strength. Even though you mentioned during your talk, initially there is decreased strength. The strength and function might be a little slower with a non-surgical approach, but long term, it looks like it's actually a really good thing for the body to heal itself and to build that up. So
yes,
really
and to be fair, if someone's a pro athlete, someone's a high level younger athlete, and they can't miss a step, they can't be 1.1 seconds off their 40, or can't lose a half an inch on their vertical, they're going to get a repair, because we think, and I think the literature does show, that repair does give us probably a little bit better or quicker function over those first 1 to 2 years, and a little bit lower re-rupture rate, a little bit better healing, so with a little bit higher risk of the surgical complications. So the non-operative protocol is very good, but it's not perfect. Cost benefit analysis.
Yeah. And can we talk about that real quick to wrap things up? The minimally invasive versus open surgical approach that you talked about. What are some differences that we have to think about from a rehab perspective and time frame and healing?
Right. So the minimally invasive is a nice in-between the non-operative and the operative. It is repairing that tendon, but it's a much smaller incision, so we have less concerns over wound complications. Once it's repaired, it's a robust repair. So the rehab protocol is in my hands no different for the minimally invasive versus the open. And for that matter, actually, my early rehab for the non-operative protocol versus the open repair versus the MIS, minimally invasive, they are quite similar. All three of those categories get put in a splint for the first couple of weeks, 2 weeks. And then after that, they're allowed to start with the early range of motion and protective weight bearing at that 2-week mark. So early on, it's actually quite similar, other than the surgical incision that has to be monitored. It's when do they get back to play, when do they get back to doing some of the more dangerous activities. And for the non-operative group, we'll probably delay that a little longer, but for the minimally invasive versus the open, tends to be the same.
Awesome. Well, thank you very much, KG Swan, sports medicine surgeon with University Orthopaedic Associates here in New Jersey. Great topic. Thanks for diving into that and breaking it down a little bit for this segment. So I wish you the best. Good luck with all your practice initiatives, and I look forward to talking with you again real soon.
Thank you very much. Pleasure to be here.